thank you for having us. And the thing is, I think it's really nice for us to be able to share that Leonie and I met at in 2019, November 2019, at the IME conference in London. And I suppose really we were both there as innovators. Yeah, we were both there as innovators, but we were only one of two, I should say now, two of three people talking about caesarean sections. So we like to think it's a little bit about where our book was conceived, really, and the whole point of the 10,000 miles apart, the 7,000 internet hours, and the 2 years that we've spent talking to one another since. We developed 55,000 words of 85 years of maternity clinical practice to put down into a book. And I suppose really the reason why we've done that, and the reason why we're here today to share with midwives and all maternity care workers who are on, is that we want to highlight our roles within C-section recovery and the crucial conversations that we should be having with women, the listening to and the acting upon, because for myself, the fourth trimester is so important. And I've walked the walk, both in clinical paths, being a scrub midwife, a labour ward midwife, and being in community as a midwife, and then making that transition into health visiting and looking at the continuity of care with women in the community. It's so important that mothers and the transition to motherhood after caesarean section, it is so different to the care that they receive in hospital and what happens to them in the community. So Leonie and I, we've both done the datics at work, we've both informed our managers, we've registered the risks, we've spoke to our unions, and we've looked at policies and worked really hard to do our own innovation and develop and work with guidelines. But it was Leonie and I's passion that once we met in London and once we realised that we were both wanting to be advocates for women's recovery, that we agreed we wanted to make a difference by doing what matters and writing the book by midwives for mothers has been that journey. So the next slide really says it all. If we could just flick to the next slide, Amy. Because once the stitches are in, the whole of the healing begins, and Leonie's going to take us through some in slide 3, some of the things, and then I'll come back to you again and we'll do some further discussion about the aim of us being here talking to you today about the recovery journey from C-section. Hey, go ahead, Leonie.
Next slide, thanks. Okay, so the World Union of Wound Healing Specialists tell us that the surgical site infection rate is between 3 and 15% after caesarean birth. And the wound separation or wound dehiscence is 2 to 8%. And we also know that thromboembolic disease, women are at risk of embolism up to 12 weeks postpartum. And I think that one situation that I encountered during my career was the death of a beautiful young mum 4 weeks after giving birth. And I know that the hospital I worked at didn't have any antenatal classes for caesarean birth, and certainly no handouts saw any information about the risk of embolism after discharge. So that I can never forget that young mum, first baby, and hearing that she died 4 weeks later, that's one of the things that has stayed with me and encouraged me to write the book and have it as a resource for not only the women and their families, but just as a reminder for midwives that this information really it is part of their role to be able to share and caution women before discharge about what might happen and what to look for. So Janine's going to talk about some of the tools that we've developed to help women monitor their own healing a little bit later. But we'll move on to the next slide now. And this is just, a wound infection on day 18. And we know that wound infections can happen up to day 30. So if a woman's discharged 24 hours after birth, and this is slowly developing, and she hasn't had any education about how to view the wound, what to look for, what does a normal wound look for. And I advocate a handheld mirror to hold down and to look every day. And we'll talk about the scar tracker later, but that's just an indication. We know that the infections occur after discharge. That rarely you would see one in hospital. So that's an important role the midwife can play in cautioning the women to be alert to the possibility. Thanks. Next slide. So I have a Facebook group called All Things C-Section, and some of the pictures that the mums post are really alarming. And as you can see here, this woman she's noticed she's got a little hole in her wound, and she's asking, is this okay? Is this normal? What should I do? And you can see, before I even got to respond, there was a woman saying, get to hospital. That's how mine started, and it exploded open. So, the women don't have this sort of information, so they're turning to social media for their advice, which is really worrying. And I'm, as a Caesar mum myself, I am a member of several Caesarean groups, and this is really common. Next slide talks about some conflicting non-evidence-based advice that's being given to women. This was someone sharing what she used to clean the wound, and down below it's talking about salt and water and surgical spirit. So we see a lot of that happening. We see a lot of the postnatal education coming through social media, and it's not always good. So we wanted to be able to provide this evidence-based information for the women to be getting good advice and not getting into trouble with things like, some of the advice they're getting. Next slide. So the World Union of Healing Specialists talk about the importance of patient education during all phases, antenatal, intrapartum, and postpartum, is critical to preventing these surgical wound complications. Now, of all of my caesareans, not one of the healthcare providers services provided any education. Now in Australia, there's a lot more hospitals. They are offering caesarean birth education, but when I had my children, there was nothing. And I was really unteachable after my Caesars. Like most women, we have a lot of analgesia on board. There's fatigue, exhaustion, the effects of the drugs. So it's really hard for midwives to be able to impart the necessary information and advice in that postpartum period, and particularly if they're only in for 24 hours. in Australia, we, have a flood of visitors, within hours of caesarean birth. So we're also up against that. It's not easy to be able to get access and to impart information that will stay for these women. So that creates quite an issue. Next slide. I'm just going to run through some of the ideas that we've come up with, and these can be all found in the book. So beginning with, I think it was 3 years ago, and this is what I brought to the IME, the surgical aftercare splint, or the SAC splint. That came out of a real frustration at work. I was finding I would maybe get 3 or 4 Caesar patients, because whether you, I'm not sure if you know that Australia, we have 37.2% Caesar rate. And so I'd go in and the first thing I would always start with was wound support, splinting your wound. And I'd say, now, do you have a rolled up towel or a cushion to hold against the wound to counter that forward thrust during sudden movements, and hopefully reduce the incidence of breakdown? And 9 times out of 10, the women hadn't had the education and certainly didn't have a rolled up towel or a cushion. So one day I was making a rolled up towel and the dad said to me, "What are you doing?" And I said, "Well, I'm just making a splint for your wife, to have nearby in case of sudden movement." And he challenged me with, isn't there anything in your storeroom designed for this? And I had to say, well, no, this is what we've been doing. This has been sort of nursing 101 for 40 years. And that got me thinking. So I went home and I created the splint that young mum is holding. And it's just basically, it imitates a rolled up towel, and I've added an elasticized belt. So women can have that. They can have it, they can be hands-free to hold their baby. And, just in those early days or weeks, just to have it nearby is a great reassurance for them and support. So that was that. Then the day planners. That was something that I thought would have been really helpful for me, because in those early weeks, the fatigue and the busyness and the pain and all the mobility limitations, that really, you sort of lose track of time. Well, I did, and sometimes I'd forget, have I had my tablets? When did I last eat? And all these sort of things. So that's where the day planner began. And then when Janine and I got together writing the book, we really grew that to 6 weeks. So in the book, there's the 6 weeks of day planners, checklists for mums to keep on track. The next section is the journal pages. So we thought it was really important to have, for mums, to have a space just to write and journal and debrief how they're feeling, how they're going, maybe, document some of their challenges, their high points. So we've created a little guideline for journaling and several blank pages with little prompts that they can fill out. So the book actually becomes a workbook because of the planners and the journal pages. The SCAR tracker, I'll leave Janine to talk a little bit more about that, but that was just another point of frustration where I thought women just don't know what's normal. And so I've started this SCAR tracker, and now we've extended it for 30 days so that women will be able to see early signs of problems. And the pain points, that's when I sat down to write down the pain points, working from top to toe, there's so many pain points that can be associated with surgical birth. and just to reassure women that, you know, they may have the headaches, they've had a general, they may have a sore throat, the shoulder tip pain, the discomfort with the breasts, and then of course the wind pains and the wound pains and constipation, all those things, and then the calf pain if they have DVTs. So to be able to just normalize that and offer simple remedies is really important, because the myth that cesarean birth is the easy way out can be, you know, debunked in just that little story about the pain points and how long it'll take them to get back to, you know, pre-pregnant fitness and activities. So that's really important. 5 Guide is Janine's wonderful tool that she's going to talk about, and debrief. Those are key points in the book. But I think I'll hand over to Janine now to finish talking about the book in more detail and how it applies to the UK situation. So thank you for listening, and I hope you enjoy the book. What you're going to hear. Next slide.
Next slide. I think, Leonie, from just hearing you talk, I think there's so many health promotion messages and crucial conversations that we have to have with women. And like you said, there isn't that time. The workforce is stretched as it is. And if women are discharged early, then it does leave little time for health promotion. But, you know, this 5 Guide tool could be your way in to be your own personal professional reminder. And like Leonie and I did come together through innovations that happened in clinical practice. Clinical practice came from my experience as a midwife, then into health visiting. And again, like Leonie, a one day wonder happening when you're with a patient. That's what happened to me. I was with a student health visitor. We were visiting a lady postpartum. It was her first day that I was visiting her as a health visitor. She'd had a C-section. And I simply said, you know, held my hand up, 5 fingers, and said, do you realise you've got 5 layers? So the hand that you can see in front of you and the 5 Guide tool is explain that I use the hand to explain the 5 layers of healing. So number 1, my thumb is your skin layer. And I'm explaining to this lady, you then got a layer behind that, your fat layer, you've got your muscle layer, you've got your peritoneal layer, and then your little finger is the incision through your womb to deliver your baby. This conversation opened up the opportunity for it. Then, as always, I said, shall I have a look at your wound and see how it is? I was horrified. The lady had got a sanitary towel over a weeping wound. The student health visitor, after we'd finished the call and the contact, and I'd explained all about wound care and referred her on, then obviously to the wound care team, said, that tool's great, Janine, you know, you really should do something with that. And literally out of that came the opportunity to go through the RCNi Foundation, and it was supported to become an innovative health promotion tool for C-section. There's a video for you to look at in the book and move on from that. But it's not for me to talk too much about 5 Guide. I just wanted you to explain to you what it is. We're nearly 200,000 caesarean sections across the UK. Nearly 1 in 3 women are having C-sections. And some of that we know why. It's going to get bigger. The agenda of women being able to have care, that they are able to make choices. The Ockenden report. Basically, you know, we've also got investigations going in induction of labour research. There's a 27% chance in my own locality that if you have an induction of labour, you're more likely to have an emergency C-section. So, yes, Leonie and I came together, and we're quite right that the antenatal prep is quite poor in Australia and in the UK, even though it's policy driven in the UK, that it almost seems a taboo subject to have with women. But I asked that question of the midwives and the student midwives and the maternity support workers and everyone on the call today. How prepared are women to be one of those 1 in 4? Are we preparing them? Are we having that crucial conversation with them? And as Leonie said, you know, they're often, if it's a planned section, if it's not, if it's an induction of labour and they've gone on to have an emergency section, sometimes they're discharged within that 24 hours. So thinking about the midwifery role, do you also realise as midwives that most health visitors haven't got a maternity background? So when you make that discharge to your health visiting team, that the competencies and skills of health visitors do not include obstetric and maternity management. Now, we're great at breastfeeding, we're great at maternal mental health, but we seem to stop at the point of wound care and whose responsibility it is to look at that wound after the midwife is discharged. Now, I know most midwives would want to hold on to a suspecting wound that may be looking a little bit iffy, but in my experience and 22 years in health visiting, most of the discharges had happened at day 10. The picture Leonie showed you was of a bone skin tone at day 18. Now, there's another issue there around wound care and ethnicity. What you see as red in a Caucasian woman, you would not see that in a bone skin. Thinking about us as midwives as well, do we do that handover properly, or are we relying on IT technology to tell the health visitor that there's been a C-section or she's had a car crash delivery? You know, the handovers aren't as good as they could be. Wound care, and as Leonie said, is our biggest fear, because we have spent some time doing some work within the book looking at postpartum sepsis, and we do refer you to a video which is on the screen now, and when you get the slides, I strongly advise you to have a look at it, because sepsis is absolutely one of the major causes of postpartum sepsis in women who've had C-section is their wound. And we jointly developed Scar Tracker in line with NICE guidelines, because we truly believe that women should be having wound care management for 30 days now. With personalised care, that can be delivered, we're hoping, with investment of self-supported, self-managed care needs, where a woman is issued and discharged with a Scar Tracker tool. It's in the book, so we're not going to reveal it all. The Scar Tracker is in the book, but what it does allow is a woman to self-monitor her wound, so that she does miss out on some of the risks that can come after caesarean section. And that's before we've even discussed anybody who has a large BMI, before we've discussed anybody who's a diabetic, before we look at anybody who smokes. And we know that Black and minority ethnic women are 5 times more likely to suffer with a lot of the postnatal and maternity complications. So we're employing to ask midwives within this talk today to look at good self-supported management, to consider the care needs of partners as well, who are left at the theatre door when it is that emergency section. There's a new report out today by dad.info, and it says men are 47 times more likely to commit suicide in the perinatal period. Now, how often do we ask dads for a birth debrief if they're the one that have had to see their partner be rushed into life-saving, baby life-saving, emergency caesarean sections? How important is the birth debrief? How important are surgical site infection rates? I'm sure to share this statistic with you is really important, that 75% of surgical site infections are evident at day 14. Now, if the handover isn't right and the care and the transition into health visiting service isn't right, just think about how many surgical site infections out there go unnoticed. And are we sadly underestimating the recovery upon discharge? You know, the take it easy, that is simply inadequate. 5 Guide has to be the new health promotion tool for you to remember what you need to say, rehearse what you need to say, and personalise it to that individual woman. Because we don't know who is looking at wounds once you discharge your ladies as midwives. We can't say, because in some areas it might be good, in some areas it's not. And within health visiting, it is an issue that I'm looking at the scope of professional competence. So, however, let's know that we've scrapped the targets on caesarean sections. So it's a free for all now, and literally with personalised care, you do have the choice to ask for a caesarean, and if inductions of labours are also encouraging the fact that the increase in caesarean section is likely to result in an emergency caesarean, then we need to encourage women to take ownership of their recovery. And that's what we hope we've done in the book. And thank you, Sue, for saying it should be the book that every mother has on discharge, because, you know, to get that investment from ICSs would be absolutely a godsend, because the risks are truly there. Do we spend enough time with the education about pain management, constipation, that headache that you get afterwards, those flu-like symptoms that may be postpartum sepsis, adhesions, blood loss, bruising, DVT, VBAC, you know, sexual relationships. It's endless health promotion. Who's doing it? It's all in the book. So, to sum up, if we want you to take away one thing in this, is the book is great. It's a mother's recovery resource. It's 85 years of nursing, midwifery, health visiting, and experiential. Leonie's had 6 caesarean sections. It's all gone in there. It's all evidence-based. Our aim is to reduce surgical site infections. We want to reduce readmissions, but we ultimately want to increase the knowledge and understanding of women so that they can self-care, they can self-manage, they can do the policy rhetoric of personalised care if they're given the tools to do it. We want to encourage good handovers to the health visitors. Why? Because there's a complexity and change in behaviour within women's health. There's a workforce crisis. We're now going to have 2 Ockenden reports. We've got nice guidelines that saying we should be monitoring women for 30 days, and we can't, but we want to. But how can we? We need to bring women as part of the care plan as well. Continuity of care has been halted in most geographical areas as well. And obviously, for me as well, the 5 times more likely BAME issue has to be raised. We've got a job to do. It's a hard job to do. Leonie and I have hopefully put a lot of that energy for you to say to women, if they've had a C-section, to recommend the book. You know, we don't get anything out of it. Our publisher takes 85%. We've not done it for that reason. It's a legacy written book. But, you know, our whole aim in the next slide, as you'll see, is just to leave that legacy so that C-section recovery, your body is returned to the health and well-being that it was before you had your baby. So Sue, I hope we've left you enough time to ask us questions and take us into the next stage. Thank you.